Discover the 3 essential actions to take when faced with sudden, severe cardiopulmonary distress. EndlessMedical.Academy educational case. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine, Board-certified nephrologist, certified hypertension specialist, internal medicine specialist. See video description for disclosures. A 60-year-old man with stage 4 chronic kidney disease from prior drug-induced acute interstitial nephritis is brought to the intensive care unit for rapidly worsening shortness of breath. He previously had Zika virus infection and has acne vulgaris. He stopped smoking 3 years ago after smoking 2 packs per day for 25 years. He works in construction and has no known allergies. His brother has hypertension and heart failure. His medications are amlodipine 10 mg daily, hydralazine 50 mg 3 times daily, furosemide 40 mg twice daily, sodium bicarbonate 650 mg twice daily, and topical tretinoin. He reports taking each dose. A prior native kidney biopsy showed interstitial inflammation and fibrosis. Immunohistochemistry was negative for an immunoglobulin G4-related process. A recent abdominal ultrasound showed bilateral echogenic kidneys without hydronephrosis. His pulse is 141 per minute, temperature is 36.7 degrees Celsius, respiratory rate is 54 per minute, blood pressure is 228 over 124 millimeters of mercury, and oxygen saturation is 94% while receiving high-flow supplemental oxygen. He is sitting upright using accessory muscles and coughing pink frothy sputum. Examination shows diffuse crackles, jugular venous distension, a third heart sound gallop, and bilateral leg edema. Scattered facial comedones are present. Chest radiography shows bilateral perihilar airspace opacities and small pleural effusions. B-type natriuretic peptide is 1,320 picograms per milliliter, normal less than 100 picograms per milliliter. Estimated glomerular filtration rate is 18 milliliters per minute per 1.73 square meters, normal, at least 60 milliliters per minute per 1.73 square meters. Potassium is 5.1 milliequivalents per liter, normal, 3.5 to 5.0 milliequivalents per liter. And high-sensitivity troponin is 28 nanograms per liter, normal, less than 19 nanograms per liter, without an evolving ischemic electrocardiographic pattern. Which treatment is most appropriate now? Option A. Begin non-invasive positive pressure ventilation. Administer oral clonidine 0.2 mg and immediate-release nifedipine, and give intravenous furosemide 80 mg. Option B. Begin non-invasive positive pressure ventilation. Start intravenous nicardipine at 5 mg per hour, titrated every 15 minutes, and give intravenous furosemide 80 mg. Option C. Begin non-invasive positive pressure ventilation. Start intravenous nitroglycerin at 5 micrograms per minute, titrated every 3 to 5 minutes, and give intravenous furosemide 80 mg. Option D. Begin high-flow oxygen alone. Give intravenous labetalol 20 mg every 10 minutes. Continue the oral vasodilators and administer intravenous furosemide 80 mg. The correct answer is option C. Begin non-invasive positive pressure ventilation. Start intravenous nitroglycerin at 5 micrograms per minute, titrated every 3 to 5 minutes, and give intravenous furosemide 80 mg. This is hypertensive emergency with acute cardiogenic pulmonary edema, often described clinically as sympathetic crashing acute pulmonary edema. Severe hypertension, extreme respiratory distress, pink frothy sputum, diffuse crackles, jugular venous distension, a third heart sound gallop, pulmonary opacities, pleural effusions, and an elevated B-type natriuretic peptide establish acute pressure-driven congestion. Non-invasive positive pressure ventilation rapidly improves oxygenation and reduces preload and left ventricular afterload. Intravenous nitroglycerin provides rapidly titratable venodilation and, at increasing doses, arterial afterload reduction. Intravenous furosemide 80 mg is reasonable because the patient is already taking 40 mg twice daily orally and has overt volume overload with stage 4 chronic kidney disease. Nicardipine lowers arterial pressure but does not provide the same immediate preload reduction as nitroglycerin and is less specifically suited to this nitrate-responsive pulmonary edema phenotype. Labetalol may reduce compensatory contractility and heart rate during acute decompensated pulmonary edema, while high-flow oxygen alone does not supply the hemodynamic benefits of positive airway pressure. Oral clonidine and immediate-release nifedipine are not appropriate titratable therapies and can cause delayed, unpredictable, or excessive pressure reduction. In summary, treatment must address respiratory failure, excessive preload, and extreme afterload simultaneously. Non-invasive ventilation, titratable intravenous nitroglycerin, and an adequate intravenous loop diuretic dose achieve those goals. Oral or poorly matched antihypertensive strategies should not delay definitive stabilization. Primary teaching point: hypertensive pulmonary edema is often driven by rapid fluid redistribution and marked afterload elevation, not simply total body fluid excess. Secondary teaching point: non-invasive ventilation and nitrates can improve physiology before diuresis becomes clinically apparent. Don't forget to like, subscribe, and share. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine. See video description for disclosures.